Okay, good evening, everyone, and welcome to July's BOMS webinar, which is very kindly supported and sponsored by Medtronic tonight. This evening, we have a great team presenting two really relevant papers. The team are from Sunderland, so it's the Bariatric MDT. Just ahead of that, I always do these announcements at the start and end. So just to let you all know that the educational webinar, which normally would have taken place on the 26th of July, the last Wednesday of the month, we've had to postpone that, unfortunately, because of the BOMS ASM, which had to be moved to the last week of July. So we look forward to seeing as many friends and colleagues there. And then we'll resume on the 11th of August for our journal club. And then the last Wednesday in August, we've got a great speaker lined up for you. But without further ado, it's my privilege and honour to introduce Peter Small, who's a consultant bariatric surgeon from Sunderland and also council member on BOMS. So welcome, Peter, and I'll hand over to you to run the journal club.
Thank you very much, Sheriff. It's an absolute delight and an honour for Sunderland to be able to present the journal club tonight. We do believe we've got a couple of really cracking papers that should cause some discussion, I think. But we're going to start, first of all, with the IHP paper, which is...
Oh, Peter, you've just been muted. Can you just unmute yourself and do the IHP paper again?
That's interesting. How did that happen? Haha. Anyway, sorry, yes. We're going to start with the IHP paper, which is about eating behaviours and weight outcomes in bariatric patients who've suffered amongst the COVID-19 outbreak. Claire Lee and Aoife McMahon, two of my dietetic team, are going to lead on this paper. And so I'll hand over to Claire, who's going to share her screen about the talk.
Okay, 1 second. Perfect. Is that working?
Yeah, that's working.
So, great. Okay. So thank you everyone for taking time out of your evening to listen to our presentation. So my name's Claire. I'm one of the dietitians at Sunderland. I'll be presenting with Aoife. She will take over from the results slide onwards. So the paper that we've chosen was called Eating Behaviours and Weight Outcomes in Bariatric Surgery Patients Amidst COVID-19, and that was published this year. The background of the paper: so the World Health Organization declared COVID-19 a global pandemic on the 11th of March 2020. Governments enforced lockdowns to stop the spread of transmission of COVID. Evidence shows that eating habits are one of the areas affected by the lockdowns, with increased intake of high-calorie food, increased snacking, and a higher number of main meals. Individuals that receive bariatric surgery may represent a particularly susceptible population to the effects of lockdown due to the impact on eating, psychological and weight loss outcomes from that. So the aim of the study was to investigate the impact of COVID-19 lockdown on treatment outcomes of post-bariatric patients in the risk period for weight regain. So it was a retrospective cohort study. Data was obtained from the parental longitudinal study. The assessments and follow-up were conducted in a hospital in the north of Portugal, and appropriate consent was obtained and ethics were approved for this. So for the methods, the participants that were involved, they had their first assessment, their initial assessment pre-surgery is classed as T0. They had their follow-up, so 1.5 years post-surgery is T1, and T2 is 3 years post-surgery. So the main difference between these two groups is that at Tier 2, with the COVID-19 group, they had their final assessment done over the telephone, so their weights were self-reported. Apart from that, during the other T0, the T1 and the T2 assessment for the non-COVID group, they were all seen in person within hospital, and all their records were handwritten and recorded. So the methods for the participants, the inclusion criteria, patients were admitted to bariatric surgery from April 2014 to April 2017 were considered eligible. The exclusion criteria included if patients had severe cognitive compromise that limited the patient's autonomy, any active psychiatric disorders, pregnancy after surgery, if the patient was unable to write or speak Portuguese, and if the patient underwent a ketogenic or a liquid diet in the months before surgery. As you can see with the participants there, the majority of the patients were female, between 83 to 94% within the groups. The majority of people either lived together or were married. The mean pre-surgery BMI was 43, and they provided the standard deviations for this as well. The majority of patients had a gastric bypass as opposed to a gastric sleeve. However, there were no statistical significant differences in the socio-demographics and the clinical variables between the COVID and the non-COVID groups. So the outcome measures that the authors used, they used the EDEQ, so that's a gold standard validated tool used to assess eating disorder psychopathology. So that looks at restraint eating, so that's restrictive eating, shape and weight concern, and food concern as well. They used the repetitive eating questionnaire, which was a Likert scale-based assessment, and higher scores revealed that the patient will be more likely to have a grazing style eating pattern as opposed to set meals. They included the UPPSP impulsive behavior scale. So that comprises of a few different tools, but they focus specifically on the negative urgency scale of this. So the negative urgency scale evaluates the tendency for someone to act impulsively under negative emotions. So for example, during the COVID-19 lockdown, when people were experiencing a lot of stress, someone might be more susceptible to having higher calorie foods or snacks or main meals during the day. So they had said the higher scores indicate greater negative urgency, so they're more likely to do that. The DAS score was also included, so that again was a 21-item self-reported measure looking at patients' depression, anxiety and stress levels, and higher scores showed greater distress. And finally, patients' weight, so they obtained that at their T0, so their first pre-surgical assessment, T1, so 1.5 years post-surgery, T2, 3 years post-surgery, and as I said previously, for the COVID group, that was self-reported over the telephone. They then looked at the percentage of weight loss regained, and they classified more than 40% as excessive regain. So I'll hand over to Aoife now.
Thanks. We go on to the next slide, please. Thank you. With the results, you'll see quite a similar trend amongst the eating patterns. And when you're looking at the graphs on the side, the dotted line indicates those participants within the COVID group, and then the continuous line is those participants within the non-COVID group. And again, the main difference being that those in the COVID group were in that 46-day lockdown for their 3-year post-op assessment. So with weight concern in graph A, that was statistically significantly higher at that 3 years in the COVID group. And same with in graph B, the negative urgency was also statistically significantly higher in that COVID group at 3 years post-surgery. Next slide, please. Going on to the other results, so with the repetitive eating, that was also statistically significantly higher at that 3 years post-op in the COVID group, and again with the compulsive grazing as well. So they all followed quite a similar pattern. When it came to the weight, it was relatively similar. They showed the T1 and the T2 assessments, which is your 1.5 year post-op and your 3 years post-op. and they stated that the COVID group exhibited significantly greater weight regain, but also the COVID group experienced excessive weight regain at a greater amount, which was 20% excessive weight regain in the COVID group versus 4.5% excessive weight regain in the non-COVID group. It was, however, difficult to obtain the raw data for the participants that were used in this study from the parental longitudinal study. And then the final point there in the results is that there were no statistical significant differences between the COVID and non-COVID group for anxiety, depression, and stress. However, there was a statistical significance as the patients went on in their journey. So from the point of assessment to 3 years post-op, there was a significant difference. In conclusion, reemergence of problematic eating behaviours occurred concurrently with that excessive weight regain that they reported. As I mentioned, statistical significance was reached at that 3-year post-op during that COVID 46 day stay at home order in Portugal, as shown by those linear models which represent weight concern, negative urgency, which was all statistically significantly higher in the COVID as opposed to the non-COVID group. This is the hypothesis that they investigated, that COVID can lead to increased disordered eating and may impact on the weight changes as well post-bariatric surgery. And just reiterating the lack of statistical difference between the COVID and non-COVID group for depression and anxiety scores, but they did note that sometimes with the pandemic, evidence has shown that there can be a delayed response, a delayed psychological response. When going through the strengths and weaknesses of the paper, in regards to the strengths, it was longitudinal in nature. They went through multiple standardized, validated, detailed questionnaires. They also looked into the psychological state of the two groups. There was a similar cohort to what's in the UK, with the majority being female and similar operations. I've mentioned the questionnaires were validated. In terms of weaknesses, there was a limited sample size. However, they did show evidence of power, limited information on how the patients were recruited, and this was difficult to obtain from the parent study, alongside the limited accessible raw data regarding the weight changes and also specifically the standard deviations to show statistical significance. And also a note that various methods of lockdown in different countries would be a weakness as well. There was a limited period within the pandemic. Obviously, we're like 16 months or something on now from that initial stay-at-home order that was also in the UK. And while they did gather quite a lot of interesting details about the marital status, education status, and whether COVID impacted on their employment status, they didn't have enough power to separate those patients into those different socioeconomic, potentially protective or risk factors in relation to those disordered eating patterns also. So the recommendations, research-wise, having a larger patient cohort and it covering various methods of lockdown in an ideal world of different countries, investigating the same factors beyond that initial 46-day lockdown. As studies suggest, there's various increased anxiety in early stages, increased depression in later stages following pandemics. Larger cohort to achieve clinical significance and power of the various socioeconomic factors, whether they're protective and risk of the disordered eating and weight patterns post-surgery, and also whether the patient themselves had any close contact with COVID. And also to provide the raw data regarding the weights. Clinical, this reflects this is similar to what we see in our bariatric clinics. There may be increased home working beyond this lockdown and potential future stay-at-home guidelines, touch wood there won't be, but we may see a rise in the aforementioned eating patterns with regards to the patterns that people are more often at home. Also consider additional dietetic or psychological support or follow or support groups for those impacted during this time. And then note that patients suffering from long COVID may experience these difficulties longer term. That whole kind of study in itself as well. and consider adjustment of both the clinician's expectations of weight loss, but also the patient's expectations of the weight that they may be able to lose pre and post surgery as well. And that's just the references, and that's everything from our presentation. If there's any, thank you. Any questions?
Thank you very much, girls. I think what we're going to do is Roxanne is now going to lead Jitka and Sally in asking the questions. So I'll pass over to Roxana now.
You've actually got me, Peter, but I'll take the stage.
Just as good.
Just as good, thank you. So thank you so much, Claire and Aoife, for your presentation. You made quite a complicated paper really clear, and thank you for providing us the detail of what all of those questionnaires meant, because there was quite a few. So I think we can all agree a very relevant paper to our practice, so thank you for choosing that paper. I think maybe the main question to ask is about how generalizable you think the findings are from that paper, which was set in Portugal. From my understanding, the data was collected very early on in the pandemic. I think they said they'd only had about 46 days of lockdown. How generalizable do you think this paper is to the UK practice in terms of what we can learn from these findings?
Oh, I'll take that one. Yeah, no, so I think that's a really interesting, an excellent point. The lockdowns between different countries were so different. And also we all experienced the difference in that immediate lockdown post-surgery. Everyone was making soda bread, whereas that wasn't quite the case when it was after Christmas in that last more recent lockdown. So I think it would be really interesting if there were more closer to home data and longer term data to make that a little bit more transferable to our clinics as well. It does show there is still things that we can get from it, a bit more of an understanding about how people react in that intensive lockdown period, and it does reflect what we see in clinics. But in order to generalize it fully, I think it would be more beneficial to get that just more throughout the longer lockdown period.
Yeah, absolutely. And I think you kind of hit the nail on the head that the first lockdown seemed very different for people compared to the later lockdowns as well. And I like you mentioned soda bread, mine was banana bread. But yes, we all sort of dealt with that in a slightly different way, didn't we? So I think that's a really good point. Jitka, is there a question you wanted to ask based on the presentation?
Yes, yeah, just I'll say, Aoife and Claire, thank you so much. I think it was an absolutely brilliant choice of paper, as Sally said, really relevant. I would just say, I appreciate there was limitations to the study, but I think the pandemic and COVID-19 is unprecedented. And I think any data is better than no data, especially with this. But I'd also, it's sort of a question about this. So I think, we have a very, very complex group of patients that we're dealing with. And again, lots of external variables going on, and a lot of things as a result of the pandemic. Our patients are trying to get a sense of control in terms of the eating and the weight loss and the preoperative and post-op. And the pandemic has sort of taken away that control. They're desperately trying to regain. But it's just, I appreciate I don't want to preempt the work that you've done already, but I think it's just sort of a question about this paper, but looking in the context of you as specialist dietitians in your own professional practice, I can see the results here fundamentally changing and the role of specialist bariatric dietitians evolving, because, the pandemic might be over, but we're going to live in a post-pandemic COVID world, and these problems aren't going to go away. Do you just sort of have any comments about future research or, the role of the dietitian that you could share with us, please?
Yeah, it's definitely important to make sure that we are working with the wider members of the MDT as well, who also have contact with these patients, so the nurses and the psychologists as well, making sure that we understand really what the patients are wanting, especially during these times, and that we're not just doing what we think's right for the patient. In terms of the role of the dietitian, I guess it's looking at what Aoife had said with their weight and their expectations, their weight loss, and just trying to support the patients as much as you can, being adaptable throughout the process, or offering more reviews, reassuring them that you're always at the end of the phone, and perhaps starting the support groups as well. Aoife, is there anything you wanted to say?
Yeah, no, I completely agree with that. When it comes to the clinical practice, just keeping in touch with how the patients are kind of responding in the consultations and linking in with the MDT, especially the psychologist, when it comes to these disordered eating patterns. And then, as you said, Claire, offering more support where possible. And then in terms of additional research, just looking at if we do implement additional support, making sure we're gathering data on that, making sure we're looking at how that has an impact on the patient, so that anyone who's doing that during COVID can showcase different methods that they're doing with those patients, if possible, with the working hours of the day.
Yeah, no, that's great. Thank you so much, but brilliant presentation. Thank you.
Thank you. Yes. So I've got a question. I think, Roxana, you wanted to ask a question that's been asked by one of our audience.
Thank you very much. Really, so some of the figures that you showed, especially in terms of kind of weight regain or excessive weight increasing over that time, looked quite stark on the graphs, but then looking at the actual difference, there's a 2 kilogram difference between the COVID and non-COVID groups. How significant do you think this is? And also, just as a second part to that question, given that, you know, we're now moving into living with COVID rather than the early periods that we've mentioned already, how much do you think these changes in terms of the weight regain are going to continue into the long run, or things will stabilize as people get back to the post-COVID world, really, and their activity?
I think, well, when it comes to clinical significance of the 2 kilograms, it seems quite small, and in numbers it is quite small, but when you consider that that's over a 46-day period, that's a little over a month, and it's in those early stages following the lockdown. And when we're looking at clinical significance for weight loss, we generally expect 5 to 10% over a 3 to 6 month period, when you're not looking at bariatric, when you're looking at conventional weight loss methods. But I know that bariatric will be significantly different. But in terms of how much someone can show difference in that time period, but also the fact that you're looking at 1.5 to 3 years, it's not that initial stage where you're losing rapid weight loss, where you might see quite a significant difference between the groups potentially in those early stages. So I think, although it does seem quite small, it's still something to keep an eye out for, because it's small but over a relatively short time period. And it would be interesting to see, as the lockdown progresses, or for patients who had their initial surgery within the lockdown and had their entire surgery experience within the lockdown, whether there'd be a bit more of a clinically significant number when it came to the weight.
Thanks, Eva. I think we've got time for one quick question from Sharif, if you'd like.
Yeah, thank you so much. And then hopefully we'll move on after. But before I post my question, so Claire and Aoife, as always happens, the audience puts on lots more questions than we can answer in the allocated time. So if you can just have a look at the Q&A button and have a go at answering a couple of these questions after, when we move on to the next talk. But my question is for the Sunderland MDT, really. So in Derby, we've had discussions back and forth endlessly about patients who've gained weight, patients who are on our waiting list who have gained weight during the pandemic, because we have a very strict rule in the unit, no weight gain, otherwise your surgery is off or you're out of the service. So have you taken a little bit more of a gentle stance, as we have, with accepting that there will be weight gain in view of the really spectacular circumstances that the COVID pressures have added onto our bariatric patients? Just a very brief answer, summary answer from anyone, really.
I think it depends on, for example, how much weight the patient has gained. A lot of the weights that we had, for example, when we started assessments as well, they're all self-reported weights. And then when we're reviewing people, they're still self-reported weights, so we do have to still take it with a pinch of salt. I think it really depends on, how much weight the patient has gained, and maybe speaking with the patient around what are their personal circumstances due to that, because it could be anything, especially during COVID. So I think it's important to try to take it more of an individual basis, but it depends on the surgeons as well.
Thank you. So I'll hand over to Pete.
Yeah, I think that's a good point to bring that one in. Thank you, Claire, Aoife. That was a very good presentation of a very interesting paper. my one criticism of that paper is that the non-COVID group, we don't know what they did during COVID. So they may actually have put on 2 kilograms themselves. There we go. Anyway, thank you for that. I now want to introduce Ahmed. I don't know where he's gone. But Ahmed is our clinical fellow, and he's going to talk to us about a paper on Barrett's esophagus after sleeve gastrectomy. There's a systematic review and meta-analysis that's been carried out in California. Again, a very topical subject. Ahmed, are you ready?
Yeah. Okay. Thank you, Peter, and thank you for BOMS for having us this evening. Is my screen? Can you see my screen?
Yeah, if you put it on to show, that'd be good. Gotcha.
So, yeah, perfect. So the paper we'll be talking about this evening is a systematic review which was published on the gastrointestinal endoscopy, a well-renowned peer-reviewed journal with a decent impact factor actually of 9.4. That's back in 2020. And it's talking about the Barrett's esophagus after sleeve gastrectomy. And the authors actually, they have published also recently looking at the Barrett's esophagus, the prevalence after obesity in general. So just a quick thank you for Medtronic for sponsoring this evening talk. The background of this paper, it was very interesting. The author himself, there is a nice interview actually on YouTube with the author, and he's talking that he went to his dentist, and while just for a regular checkup, and his dentist actually raised the question that he had lots of patients post-bariatric procedures who present with the erosions and to their teeth. So he was asking what was sort of bariatric procedures they had. So that actually led the author get interested in that topic. And that's why he went to dig, and this is how the question was raised. So obesity is going up, and sleeve gastrectomy is nowadays a commonly performed bariatric procedure, and that's a combination of technically it's has a less complicated compared with other procedures, as well as a decent outcomes. Unfortunately, the downside of sleeve gastrectomy is GERD, or reflux, gastroesophageal reflux disease, unfortunately, which is a known precursor to Barrett's esophagus. Barrett's esophagus is a metaplasia of the lower esophagus due to exposure to reflux acid, and unfortunately, with long exposure, that might progress into dysplasia and eventually to esophageal cancer. Just a quick as well polish about Barrett's esophagus and the sort of risk of developing adenocarcinoma. If there's any non-dysplastic changes, then it's very low, which is less than 0.5% per year. But we can go all the way up to 7% progression to neoplastic progression if you have high-grade dysplasia. So far, there are no sort of guidance or guidelines for these patients, but the ASG, which is the Association of American Society of Gastroenterologists, they have a recommendation that any patient with a prevalence of Barrett's esophagus more than 10%, then these patients should be offered screening. So methodology, this is a systematic review and meta-analysis, which goes up high on the hierarchy of evidence. But when it comes to systematic review and meta-analysis, there should be some sort of quality control factors to avoid having any issues with publication bias, issues with the heterogeneity. So these are the sort of things. So systematic review and meta-analysis, the authors had the help of an expert librarian, and they had a look on the standard search engines up to July 2020. They assessed the quality of all the papers which they have included in their analysis, and they have different types of validated tests. But the one they have used was Downs and Black scoring system, and also they have used a panel plot for publication to ensure that there's no publication bias. With the fact with any sort of meta-analysis, there will always be some issues with heterogeneity. And especially when we're talking about Barrett's esophagus, there is wide variation. Topics or points that have been highlighted was variation of definition of GERD. There are again different systems of how to define these follow-ups, different health systems, different countries, different institutes, and they have different follow-up protocols. Prevalence of GERD as in the baseline population, again, as we will have a look shortly on their papers, there is a wide variation in terms of the baseline population between South American as well as West European. They have followed the PRISMA guidelines as expected for any systematic reviews and meta-analysis. And this are the inclusion criteria and exclusion criteria for the papers or the articles they have included. The inclusion criteria, they have involved all of the RCTs, which I don't think for such topic you'll find any RCTs. We're talking about prevalence. So in these cases, cohort studies are the most helpful. So cohort studies, prospective retrospectives, or even they had a look on any abstracts within the last 3 years. The catch is all patients should have sleeve gastrectomy for obesity. And the patient should have an OGD pre-op, which I understand this is the standard in most. And I put the line under most because not all centers actually do OGDs pre-op, or at least one of the centers I've worked in before. And then the study authors should invite patients to have an OGD post-operatively. And that should be all patients. So it's not like selectively or symptomatic patients. And when it comes to Barrett's esophagus, it should be confirmed both endoscopically as well as histological. The exclusion criteria where any patient who had an OGD just for the cause of symptoms post-operatively before that patient is off or that paper is off, case series or case reports and poor quality papers and the ones that are not available in English language. The outcomes which they have said, which was mainly the prevalence of Barrett's esophagus, which was the proportion of patients who developed esophagus after having a sleeve gastrectomy. And as I mentioned earlier, should be both endoscopically as well as histologic diagnosis. And beyond that, they have to stratify Barrett's esophagus both on if the patients had any reflux symptoms, when did they develop it, as well as was any esophagitis on the follow-up OGD or not. They have also said some secondary outcomes, and it's mainly prevalence of esophagitis in these patients post-sleeve gastrectomy, and also do these patients prevalence of GERD on the follow-up. So this is the flow chart and PRISMA flow chart, which has shown that they started with 4,389 studies, but at the end they ended only having 10 studies in the final analysis, with a total of 680 patients. All of these patients had OGD preoperatively, and then all these patients have OGD postoperatively, minimum 6 months. It's a massive table, and for the people who had a look on the paper itself, it's a massive table, and that's why we have to split it actually into 2 slides. But let's have a look, start with this one, which is on the left-hand side, as you can see, is all of the papers or the articles that has been included. All of them were prospective. And when it comes to countries, you could see, I mean, there is much, but it goes all the way from West Europe into Southeast Asia and down to South America. And mean age, again, it has been wide variation in terms of the patient ages. But the one I would like this to highlight in this one is mainly the OG size. And you can see still, I mean, in Sunderland, at least we use normally 36, but it's interesting that still some people, they go up all the way to 48. The part of the rest of the table, it can show as well the follow-up. And the follow-up is, again, there's a massive variation in that. It could be as minimum as 6 months all the way into 10 years, as is very interesting itself. And then it comes to the patients who develop Barrett's esophagus post-sleeve gastrectomy. And there are 3 papers that they didn't have any patients who develop Barrett's esophagus. The last column on the right-hand side of the screen, which is the DMB, this is the test which they have used to test for the quality of the papers. And what they have done is they give it a score. I mean, there is a checklist, and normally they give it a score. And anything between 12 to 16, actually, this means it's a good quality paper, and anything below 6 is poor quality. But it looks like from these ones, all of these ones actually looks very reasonable, at least moderate to good quality of papers that have been included in the analysis. So the other thing which they have mentioned is they have the paper from the follow-up point of view into short-term and long-term. The long-term is anything 3 years and more, and anything below that is going to be considered as short-term. And out of this, then we ended having 7 studies with long-term follow-ups and 3 studies with 6 months up to 3 years short-term follow-up. The things which we have to consider with any, which I have to mention, is considered as a bonus for this paper, is they have to ensure their quality, and that's why they have used done in black, as I mentioned, and also publication bias was assessed. So let's get back into the results, and what they have found is the prevalence of Barrett's esophagus overall from the 680 patients, 54 patients of these have developed Barrett's esophagus, and that will give us a co-prevalence of 11.4. All cases of Barrett's esophagus were non-dysplastic, and if we go into one of the very few early slides on this presentation, when non-dysplastic, low grade or high grade, so all of these were non-dysplastic. De novo, which means that all of them, they developed this Barrett's esophagus after the sleeve gastrectomy. And all of them were actually shown on the 7 studies for the long term. This is just the first plot, and you can have a look on those, and that's, we can just on the left-hand side, it tells you the papers with the follow-up, and as you can see, I mean, the 3 papers that didn't have any Barrett's esophagus patients, these were on the 0 line, and then all of the other ones were actually on the right-hand side. And this is the final plot looking at all patients, sorry, all the papers, just to look for any publication bias, which is not obvious in this paper. Then they look at the Barrett's esophagus in relation to GERD symptoms. And they look at the patients who had with or without post-operative GERD symptoms. And what they had a look at, there were 7 patients who had Barrett's esophagus, but surprisingly, they didn't have any GERD symptoms at all. That shows you that obviously very, very interesting point, because if we are going to have a look on these patients as a long term, we are not going to rely only on patients who have reflux symptoms, because patients could be asymptomatic, but despite that, they might actually have Barrett's esophagus. But there was no significant heterogeneity in that group. There was significant association between the mean age and the prevalence of GERD when controlling for GERD and follow-up time. And this is one of, if you go back into the basic of the Barrett's esophagus, age is very crucial, as well as the long-term follow-up. When they look at the significance between Barrett's esophagus and duration of follow-up, they didn't have much. It's a bit confusing, this part, because it's not the follow-up that actually leads to Barrett's esophagus, but actually it's the reflux. This is the thing that leads to the Barrett's esophagus, but not the follow-up itself. And this is, I mean, this last paragraph has to be just taken cautiously. Then these are the ones we are looking at, which is esophagitis after sleeve gastrectomy. These are the secondary outcomes. And out of the 7 studies reported esophagitis before and after sleeve gastrectomy at various follow-up intervals, they have to exclude 1 study from their analysis, and the main reason for that was the surgeons were actually just starting doing the sleeve gastrectomy, and they were considered as early in their learning curve. Therefore, that paper was excluded. Overall, there was an 86% increase in the risk of esophagitis on long-term follow-up, with a significant p-value on that one. Even for the short-term studies, there were also 35% increase. So that is, again, very significant for esophagitis post-sleeve gastrectomy. And this is again the. So let's go to GERD after sleeve gastrectomy. And overall, there's 8 studies reported the rate of GERD after sleeve gastrectomy, but they have to exclude one. And the main one, that one has been excluded mainly because there was some sort of, the definition of their GERD was slightly vague. That's why it has to be excluded. All studies show the effect estimate to be in the same direction. There is lots of heterogeneity. And if we go back into, I will go back into, just look at this column down here. And what has shown that there is a massive variation between the heterogeneity and definition of GERD. And that's why it has shown there's between 1.6 to 49. This is a massive variation in the heterogeneity. But overall, it shows that there is still the effect estimate is more or less the same line. 4 studies reported de novo GERD after sleeve gastrectomy, which means that patient didn't have any GERD before the sleeve gastrectomy, but unfortunately they developed it after the sleeve gastrectomy. And 2 papers they have reported on the use of PPIs, and they have shown that one of the papers increased from 23% preoperatively to 74 or 75%. Another paper more or less showed the same. So definitely there is increase in the proton pump inhibitors comparatively between the 2 studies. So when it comes to discussion point of view, there's been lots of studies in the past that have been looking at mainly as GERD and erosive esophagitis after sleeve gastrectomy. There is one meta-analysis in which the author have just mentioned, but that was part of some analysis in which they reported the poor prevalence of Barrett's esophagus was almost 8%. But overall, there were no previous papers or meta-analysis that has studied this topic. Barrett's esophagus was not limited to patients with GERD symptoms, as we have seen earlier. And I would notice as well that most of these cases, of all of them actually, all of these patients were picked up 3 years after sleeve gastrectomy, and all the way up to 10 years in terms of follow-up. How can we put this into clinical setting? So the risk and benefits of screening for Barrett's esophagus, as I mentioned earlier, that the only guidance so far we have is the ASG endoscopy guidelines, which they say that patients with prevalence of more than 10%, these are the patients that should be offered screening. Screening might be started at 3 years, but this is when it was the earliest point it was actually picked. And also, one of the things we have been picked is starting acid suppression PPI should be started early during the course. The increased risk of Barrett's esophagus due to sleeve gastrectomy should be discussed with the patients, and anyone who was deemed to be at higher risk preoperatively, then other surgical options should be discussed with the patients. Barrett's esophagus in this population can be considered seriously in view because these patients have other GI symptoms, and therefore it might mask their symptoms, and therefore these patients might actually be missed for having any further tests. The other thing which I have just mentioned here is endoscopic sleeve gastroplasty. This is a procedure that is gaining more and more gear actually, and people are getting more comfortable with it, which acts the same, mimic the same as sleeve gastrectomy in terms of weight loss as a weight loss procedure. It has the sort of available data so far. It shows less reflux symptoms, but as a long term, we don't know which would have the same impact as Barrett's esophagus or not. Something need to be looked at. And the risk of erosive esophagitis was found to be very high in patients post sleeve gastrectomy, with a 13% increase in risk of esophagitis every single year post-operatively. All studies show the high prevalence of GERD post-operatively, and 40%, which is a decent number actually, of patients develop GERD post-operatively. Strength of this paper, it's as mentioned earlier, there are lots of papers who spoke about erosive esophagitis. They might have considered Barrett's esophagus as secondary outcomes. There's one, yeah.
Can I? We're running out of time. Could we?
Okay.
We know about the strengths of the papers. Maybe we should put some questions.
Okay. So my prevalence of Barrett's esophagus is high. Yeah.
Yeah, that's good. Sally, Sheriff, do you have any questions you want to put to Ahmed?
Sure, go ahead. Thank you so much, Ahmed. That was a fantastic
Sorry, it has
presentation.
just been a bit quick one, sorry. Yeah.
No, incredibly detailed. And I'm sure actually this will be a fantastic resource for trainees if you wanted to share it later on as well. Obviously, this is a topic that we could talk about for many hours, but in the interest of time, I've just got a quick question. It wasn't clear whether the authors had actually looked at whether all of the studies they included had done pre-op endoscopies as well. So I was just wondering how we could be sure that all of the cases they were detecting were in fact de novo Barrett's esophagus. And just as a little kind of, in light of that, kind of given what do you think would be the ideal regime of pre and post-op endoscopy, given these quite stark findings that you've presented?
So in terms of pre-op OGDs, I mean, that's a standard. I mean, at least, I mean, I know it's not all centers. They don't do, not all centers do OGD. I mean, that's routinely. But I think this is from BOM's guidelines. I mean, this should be, all patients should be offered an OGD pre-operatively. From that, I have to say is whoever does OGDs normally, they have to be well trained in terms of picking Barrett's esophagus, which is something that needs to be looked at in terms of training from it comes to JAG from that point of view. Especially have surgeons, you have gastroenterologists, you have endoscopists. So people should be trained well in terms of picking the Barrett's esophagus. That's one thing. In terms of, again, has to be patients who have post-sleeve gastrectomy. I think we should be able to offer them an OGD post-operatively as part of their follow-up before actually being discharged into the community.
Okay, thank you. Sally?
Yeah, so I guess I've got a question, but I guess the response probably just needs to be as brief as possible in sort of the need of time. But I was quite shocked to read in this paper that they'd calculated that there was an 8% risk of esophagitis per year after a sleeve gastrectomy. And it just got me thinking about patients' quality of life after surgery, particularly if they don't respond to PPIs. And I just wondered, from a surgical perspective, do you think we do enough in the preoperative stage to counsel patients that undergo sleeve gastrectomy about the risks of esophagitis and GERD after surgery? I'd just be interested in your opinion there.
I think at least in Sunderland we do. But again, there's one of the points normally is going to be between patients who have symptomatic or someone who had an endoscopic esophagitis or gastritis, smokers. So all of these patients, actually, they are deemed a bit of high risk to develop post-op esophagitis. So definitely in these patients, you'll be able to give them more, they are high risk of developing post-op esophagitis. But on the other hand, getting to your question, how much other centers they do, I think there might be wide variation. And there is a reason that the sleeve gastrectomy is going up. Can tell you that patients might not be actually aware that as a long term, they actually might develop this esophagitis.
Yeah, thank you. I'd agree.
Thank you very much, Ahmed. So we've overrun by about 5 minutes.
Oh, sorry for that.
But it is a paper that really needs a lot more time to discuss. And well done, and thank you very much for your clear presentation. If the panelists don't mind, I'd like to just thank very much the team from Sunderland. Peter and colleagues, and I'd like to really thank the co-chairs, so Sally, Yitka and Roxana. Thank you very much for giving up your time. So we look forward to seeing you for the next Journal Club, second Wednesday in August 11th. Thank you very much for attending, and apologies for the slight delay, and thanks to Medtronic and to all of you again.
Thank you.